All right, well, thank you again, everybody, for your time this morning. My name is Matthew Menendez with White Plume. I'm going to be walking through the webinar today, and I hope that this will be helpful for you. What we're talking about, this is specifically designed for physician practices. We're going to be talking about some of the financial implications, productivity implications in a post-ICD-10 world. How do we make sure that we avoid some of the pitfalls that are still ahead of us? It's hard to believe that ICD-10 Day was just 3 weeks ago. It seems like a long time ago, right? We've been working towards ICD-10 for a very long period of time, and now we are in that world. It's very tempting to view that all in the rearview mirror, thinking that that all has gone well, that all is safe, and there's not much more to worry about. But I would caution you against that. October 1st is really the starting line for ICD-10, not the finish line. So what we're going to do today, what I hope to accomplish here in the next 45 minutes, I'm going to give you some general background information, take a little bit of a different approach to looking at what ICD-10 looks like. We're going to look at some of the things that make ICD-10 uniquely difficult here in the United States, right? There's some things that our government has done that makes that more challenging for our physician community than a lot of other countries. We're going to look at the false sense of security that a lot of people have because October 1st seemed to come and go without a nationwide meltdown, right? There are still some hurdles that we have to clear before we can declare victory over ICD-10. And one of the risks associated with that false sense of security is developing some bad habits, getting into some bad workflows that you're going to have to change later. We want to make sure that we don't do that. And the two areas that we're going to focus on are what I believe are the two greatest risks associated with ICD-10 for physician practices. And number one is physician productivity. Think about it this way. If your doctors are not taking care of your patients, nobody else is. If your doctors aren't generating revenue for the practice, nobody else is. And if your doctors aren't happy, nobody else in the practice will be either. We have to protect their time and not turn our doctors into coders, right? But closely behind it is the risk and the impact that ICD-10 has on the revenue cycle. We all know that we have to be able to take those patient encounters and turn those into claims that are ultimately paid, and do that very efficiently without adding a lot of staff or without adding a lot of steps to the process or making that a longer process, right? If the revenue cycle takes longer to manage or takes more people to manage or produces less cash flow at the end of the day, those are bad outcomes that we have to avoid as we're navigating ICD-10. And so we'll share some of the things to look out for, to be on the watch for, so that we can be preventative rather than reactive. I'll make sure that we leave time for questions and answers at the end. So again, if you're just joining us, welcome. Locate the questions panel on the far right, and you can ask questions as we go. So the question is, what makes ICD-10 difficult? What makes it uniquely difficult here in the United States? How do we get into that false sense of security? You know, let's dive in and take a look at this. Most everybody knows that ICD-10 was a one-day conversion, right? That began on Thursday, October the 1st. That was the magic day where we had to convert over to ICD-10. But a lot of people look at that and say, hey, that's behind us. We've got this. We've succeeded. Our world hasn't ended. You know, we've been able to continue to see patients. We've been able to continue to submit claims. You know, we're still waiting to see how those claims get paid, but we feel pretty good about where we are so far. We've got to be vigilant. You have to continue to watch out, because it's not just a one-day change, right? ICD-10 began on Thursday, October the 1st, but we've used ICD-9 for 30 years. We're going to use ICD-10 for many years to come. ICD-11 probably will not hit us for another 7 or 8 years at a minimum. And one of the concerns, one of the things that the government has done that makes this more difficult, that generates this false sense of security, is the confusion around unspecified codes. Right? I'm sure most people are aware this summer CMS came out in a joint press release with the AMA to say CMS will not, or Medicare will not, deny claims only because of an unspecified code. This was supposed to be an olive branch to the provider community over the pushback of the increased specificity in ICD-10 that says as long as you're in the right code family, we won't deny that claim for the first 12 months. Now, there are a couple of problems with that. Number one, it doesn't impact commercial carriers. We're still waiting to see how they are going to respond. But number two, it allows you to create some bad habits during those 12 months that are eventually going to have to change. I'll tell you a quick story. A provider that I was talking to asked me some questions about this and trying to understand what the statement from CMS meant. And so the conclusion that he took away after asking a few questions and making sure that he understood was, well, we're just going to use all unspecified codes, and we'll deal with that later. And that may be a workable strategy for today, but it sets you up for failure later. It makes that more difficult once those bad habits become entrenched, and that's one of the things that makes ICD-10 hard. Now, another thing that makes ICD-10 hard for practices here in the United States is that it's a big change for our physicians, right? Nobody likes change. Physicians certainly don't like change. Now, you could say, well, wasn't it a big change for doctors in Canada and Australia and New Zealand and England and France when they moved to ICD-10? Sure, but our doctors are not like those doctors. Our doctors are not government employees. They're small business owners. They are paid in today's fee-for-service world based on their volume, based on their productivity. They cannot slow down to deal with an unfunded mandate like ICD-10. That makes it very, very difficult. And so many practices, many doctors don't want to spend the time, don't want to spend the energy, the effort to really understand what needs to happen in an ICD-10 world. They want to be able to learn very quickly, and many may be taking shortcuts that are producing suboptimal results, or that will produce suboptimal results in the future. Now, the last piece is what I think makes this most difficult, and it's what's at stake. We've had a lot of change in our industry over the last 6-7 years, right? PQRI, which became PQRS, e-prescribing, meaningful use stage 2. It seems like an endless parade of regulation coming out of Washington. Then ICD-10 can feel like just another step in that direction. But all of those other programs that I mentioned were voluntary, were Medicare, Medicaid only, offered an incentive for doctors who did it successfully. There's a threat of a future penalty. And ICD-10 is very, very different on all of those elements. It's mandatory, not optional. There's no incentive plan. It's all of your payers. So what's at stake is much larger. It's not 2% of your Medicare reimbursement. It's 100% of your cash flow, because all HIPAA-covered entities, all payers, are required to move to ICD-10 by law. And so that says we have to do this, and you have to do it correctly, right? And it's not just about what I call ICD-10 compliance, meaning getting the codes on a claim out the door. No, you still have to jump through the hoops and hurdles that the payers set forward to make sure that you get the claims paid completely and correctly. And again, you probably already know this, that's not a stationary target. Those evolve over time. That was true in ICD-9. That continues to be true in ICD-10. And we're going to see that over the next 12 months. So yes, it helps to recognize, yes, ICD-10 is hard. Yes, it is a big project. Yes, it's something that you've been working on for a long time, but don't declare victory too early. You know, if you've been watching, kind of keeping an eye on blogs and press releases, that sort of thing, over the last few weeks, you know, you've seen a lot of people with this false sense of security, right? I saw a lot of PM vendors, a lot of EHR vendors on day one declare victory. Our clients have been successful with ICD-10, and that's great. They put in a lot of energy and effort to make sure that that happened, right? And hopefully your vendor performed well on day one to make that a non-event for most of your staff, right? And then everybody was holding their breath and waiting to see what was going to happen with the clearinghouse and the payers. Had they done their work? Were they going to be able to receive this information? Were we going to have a data problem, right? That a lot of people were concerned about. And the payers have been very quick to point out that they were ready, that they have not seen a statistically significant increase in the number of rejections, right? And the key word there is rejections, because what at MGMA in Nashville, the payers were very quick to point out they have not seen that. And what that means is their systems were ready. They could receive the ICD-10 codes. The data was passing back and forth. So there was no meltdown on their watch. But the question that still remains out there is for the practices. Is your workflow ready? Were you capturing the right codes? Are those going to get denied? Yes, we know the payer didn't reject them, but are they going to deny that claim? And we don't know what that looks like yet. And we won't know the final answer for probably more than a year. And the reason why is the payers are going to change. Payers don't do that the same way. Blue Cross handles it different than United. United handles it different than Medicare. And they are not consistent with themselves over time, right? That changes from month to month, from quarter to quarter. And we're going to see a lot of change from the payers in ICD-10 because the payers have not done this before either. So yes, most of our systems were able to handle ICD-10 codes, and that is a great step forward. But we've got to go deeper than that and make sure that our workflow is set up to produce the types of results you require in your revenue cycle, and do that in a way without slowing down your doctors, do that in a way without having to add additional staff. So we're going to talk more about that. But what we want to keep in mind are the big risks associated with ICD-10, right? Remember, we talked about the two big risks are a risk in decreasing physician productivity. That's risk number one when we look at ICD-10. And risk number two is a decrease in revenue cycle efficiency. And when I say revenue cycle efficiency, what I mean is think about what it takes today. How many people, how many labor hours, what does it take to get your claims paid correctly and completely? What are the inputs? What are the outputs? And then when we move into this ICD-10 world, and as we work through that over the next 12 months, what will be the inputs and what will be the outputs? Because ICD-10 is an unfunded mandate, if it takes more time, that's a bad outcome. If it produces worse results, that's a bad outcome. That's unacceptable in an unfunded mandate. Okay? And what you hear a lot of people talk about when they in the move to ICD-10 are the number of new codes in the code set, right? You hear people talk about 69,000 diagnosis codes in ICD-10, and what you probably already learned is you're not going to use all of those. You need to focus on the codes that you do use, right? How do those work? How do those filter through our process? How are they captured by the physician, by the clinical staff, and how does that flow over to the billing team, right? What does it take for them to make sure that all of that gets put into the practice management system and sent out to the clearinghouse and sent over to the payer? You know, you're going through that process right now. The tricky part is when you get to the end of that process. if you don't get the desired outcome, that work comes back on the billing team, back on the physician at the top of that process. And if you're using, when you look at the codes that you're using today, a lot of people are using unspecified codes. Those work today, but over time, it may not be for another 12 months. For some of your payers, it may be in 90 days, they're going to start to deny those claims. And let me show you a couple of examples. It might help you. The codes that people like to talk about in ICD-10, they like to make fun of, they point to as kind of ridiculous, are some of these crazy codes, right? You guys have probably seen this before. The famous water skis on fire, right? That's a valid ICD-10 code. You can go look it up in the book, but I bet you nobody's used it. And what most people won't tell you is that was actually a valid code in ICD-9. It was an E code, an external cause code. Most practices do not use those, and CMS has already come out and said, if you're not using external cause codes today, and if you don't use them in ICD-9, you're not going to, there's no new national mandate requiring you to use those in ICD-10. These codes are a distraction. It gets people focusing on things that really don't matter to them. And it distracts them away from the silent killer. It distracts them away from what might give them a false sense of security that is going to cause a major problem for them later. And I'm talking about unspecified codes, right? You can be very, very unspecific in ICD-10, just like you could in ICD-9. Now, the problem was in ICD-9, when practices would use an unspecified code, as many practices would, there weren't negative consequences. In ICD-9, for the most part, it was a payable diagnosis. So it made sense to use an unspecified code to save space on an encounter form, to make your cheat sheet shorter, to make the template in your EHR easier, to use it as a catch-all. There were no negative consequences to that. They were payable diagnoses. But as we transition to ICD-10, there is risk to using those unspecified codes. There are two risks, actually, a short-term risk and a long-term risk. So let me address both of those. The short-term risk to using unspecified codes in ICD-10 is that eventually those claims are not going to get paid. Right? Remember my story about the doctor who said, well, we'll just use all unspecified codes until they start denying those claims. Right? He knew that eventually they're going to start denying those claims. And the reason why is if you zoom out and think about why have the payers invested in ICD-10? Why have they rewritten their adjudication algorithms? Why did they lobby Congress to continue moving forward with ICD-10? It's because the data is valuable to them. The data is valuable to the payers. They want the more detailed diagnosis codes. They want the more granular disease information on their patient population. And if the provider community does not give that to them, they are going to deny those claims. Now, that probably won't happen day one. It may not happen this year, but that will happen. We know that that will begin happening next October for Medicare, probably sooner for your other payers. Don't start off with bad habits. Don't start off with bad workflow processes that you're going to have to re-engineer later. An ounce of prevention here is better than a pound of cure. What's the long-term risk? The long-term risk with using these unspecified codes in ICD-10 is that eventually we're moving away from the fee-for-service world. We're moving towards an outcomes-based reimbursement world. Pay for performance, pay for quality, right? Call it what you'd like, but that's where the payer community, that's where the government wants to go. And in that world, it's all about expected outcome versus actual outcome. It's all about being able to show how sick your patients are. and the quality of care your providers are undoubtedly providing. But we've got to be able to show it. We've got to be able to use the more specific ICD-10 codes to show how sick my patients are, to maximize and maintain my reimbursement in that environment. And so you see there is a short-term risk and a long-term risk to using these unspecified codes. You may not feel the pain of that today, but in a way, having that piece of this delayed will actually make ICD-10 take longer and be more painful for a lot of practices. Not everybody will be able to take this recommendation, but the recommendation is start off doing it correctly. If you can do it in a way that protects your doctor's time and produces the right type of outcome for your revenue cycle. You know, let me give you an example. I see a lot of practices that use this today, right? They use osteoarthritis of the lower leg, osteoarthritis of the knee, very common code that gets used. And if you, depending on how you do this, if you organize it through a cheat sheet, one of what it'll say is, oh, you can automatically do that. You can replace it with M17.9, osteoarthritis of the knee. Now, the problem with that is it's unspecified as far as the type of osteoarthrosis. Is it primary? Is it secondary? Is it post-traumatic? It's also unspecified as far as which knee, right? And this is one of the things that Medicare actually said they will deny claims for, is if you do not specify laterality. You know, you look down at that list, if you go look up osteoarthritis of the knee in the ICD-10 book, you'll see all these choices, but you'll see that there are valid codes that say, we don't know which knee it was, right? So you've got to be careful there. You've got to be careful there to make sure you're not turning your doctors into coders. You've got to be careful to make sure how your process, how your workflow is designed to make sure that you get the right result. Because otherwise, you've got a claim that's going to get denied. Maybe not today, maybe not tomorrow, but certainly as we get further and further into the ICD-10 world. So you go back to your workflow and you think about that. Today, if they're using the unspecified code, not a problem. It goes from the doctor, it goes to the biller. The biller can key that valid code into the practice management system, or it can pass across an interface, right? It can go out the door to the clearinghouse. They accept it because it's a valid ICD-10 code. So does the payer, right? It doesn't get rejected on the front end of their process, but when they adjudicate that claim is going to get denied, or the claim is going to be paid at a reduced rate. And when you get to that problem, right, that's when we're really going to get into the detailed, sticky parts that make ICD-10 difficult. Because what's going to happen is you're going to go back through this cycle up at the top of this process, right? The biller or the AR rep or the revenue cycle rep is going to see that denial. It's going to slow down their process. They're going to have to go ask the doctor or go review the note to be more specific. The doctor's not going to answer the query the first time, so they're going to have to ask again. It's taking longer and longer to get that claim paid. It slows down that process, and that's where the risk is for the practice, for the provider, and for the revenue cycle. Let me share a couple of studies with you that kind of put some numbers to that. This first study was done by Nachemson Advisors. They're trying to look at what are the costs for a physician practice to transition to ICD-10. A lot of numbers on this screen, but let me try to explain it quickly for you. They grouped practices into small, medium, large. That was roughly 3 doctors, 10 doctors, 100 doctors in a practice. And then they broke down the cost into 2 major sections: pre-implementation costs, which are thankfully in the rearview mirror, and then post-implementation costs, which are still ahead of us. Now, if you look closely, what you'll notice is the post-implementation costs are much larger than the pre-implementation costs. A lot of people were focused on the pre-implementation cost and haven't yet paid attention to the post-implementation cost. But look at what they say. They say the costs of post-implementation are in two areas: productivity loss, meaning if it takes your doctors more time, if they have to answer more of those queries, if they are looking through a code book, they're drilling down through the EHR, right? That's time that they never get back. They lose that every single day. It's a recurring cost, and it's quite large. And then you also have the payment disruption cost. The study's authors asked Medicare, what do you expect to see from a denial perspective following ICD-10? And the answer was that they expected denials to double or triple as a result of ICD-10. Now, we're not going to see that immediately, right? I told you that's going to get phased in over time. And that's a bit more difficult to deal with. That's why I think that what the government has done really hurts practices, because it's the slow boil. It's the slow boil of the frog, right? Everybody knows that illustration, right? If you put a frog into boiling water, they hop out. But if you put a frog into warm water and slowly turn up the heat, they don't notice the difference. And that's the concern with the way CMS has structured this, is you may find that you don't see that payment disruption all at once. Because if you did, you'd respond to that very, very quickly. If it happens slowly over time, practices may add staff. Practices may slowly see their cash flow get worse and worse. You may turn around at the end of 2016 and say, wait a minute, what happened when we're trying to pay out quarterly physician bonuses, or we're trying to pay Christmas bonuses to staff? Why are we less profitable, right? And it's been that slow boil. That's why we want to put in measures to prevent against that. Another study that was done by the advisory board. They do some very, very good consulting work. They looked at Canada's transition to ICD-10 and said, what are the productivity costs there? What did they see, and what can we expect to see here in the United States? Now, if you look at what they put front and center, it's physician productivity. And they saw physician productivity losses of 10 to 20% as a result of ICD-10. Now, when you have nationalized health care and doctors or government employees in Canada, maybe that's acceptable. But that won't work here in the United States. That won't work in a busy practice. Your doctors have to be taking care of your patients. That's what they're best at. That's what they're trained in. That's what they want to be doing with their careers. And you want to get underneath those numbers and understand what was happening. The decrease in physician productivity was because doctors were spending 45 to 90 minutes per doctor per day answering those types of follow-up questions from the billers, from the coders. Where are your even if you cut that in half, where will your doctors find an extra 22 to 45 minutes in their day? Are they going to see fewer patients? Absolutely not. Is it okay for them just to get behind in their schedule? Right? No, that's the thing everybody hates the most. And it's unfair to expect them to answer these questions at the end of the day rather than spending that time with their families. We have to protect against this. Don't let this turn into a slow boil in your practice. On the far left-hand side, they talk about coder productivity, and you see a significant decline in the first year. Right? That's the bad news. The good news is they will get up that learning curve, right, and regain a lot of that productivity as they get more comfortable, as they get more familiar with ICD-10. But they never get back to pre-ICD-10 productivity levels, right? There's a long-term projected decrease of 5 to 10% productivity for coders or for billers. If you don't have coders in your office, you can replace that with billers. And that's not their fault. ICD-10 is more difficult. It's like learning a new language. And they have to get familiar with that. And it is more complicated. It requires deeper thinking. It requires deeper coding. It requires deeper detail for ICD-10, right? And how do we do that if we can't add additional staff? Not to mention the fact that if there are more questions going back to the doctors, the coder, the biller, is going to be the person who's having to remind and do that follow-up work, right? That stays on their plate to get that additional information from the physician. And then on the far right, you see they have the rework productivity here as well as an increased amount of work because of the increased denials. That matches up pretty well with the Nachemson Advisors report. So I show you that information just to try to shed some light on what's coming, on what to look for, and how to start to think about that so that you can make sure that you avoid some of these, so that you put some of the processes in place to make sure that you're capturing the right data, that you're doing that the first time, but doing it without turning your doctor into a coder. So let me show you 3 kind of options of what we've seen practices do to try to protect against this, right? The first option is really to hire certified coders. Hire more coders in the practice to do this work. The doctors have to document, the coders will do the coding, right? That works well in the hospital world, in the inpatient world, not so much in the physician practice, but I mentioned it to you anyway. Here's the reason why that typically breaks down for practices is coders are expensive and they're getting more expensive, right? Simple laws of supply and demand. Everybody remembers this from Econ 101. There are not enough coders, right? Hospitals are hiring them as quickly as they can, so the supply is going down. At the same time, more people are looking for them. The demand's going up. When that happens, it makes them more expensive, right? And since there's no additional revenue from ICD-10, it's very hard to make that work in your practice. So they're getting more expensive. At the same time, they're getting less productive, right? They're not going to be as productive in ICD-10 as they were in ICD-9. So if it didn't make sense for your practice 3 years ago, it probably makes worse sense now. But I do want to throw that out there as an option because some practices are doing that. Another way to do it, and this one sounds easy for me to say, and maybe more difficult for some of you to do, is to get your doctors to do this correctly in their EHR, right? But you get a lot of pushback on that, right? Doctors don't want to be data entry employees, right? And it's not because they're technology averse or because they like being non-compliant. No, it's because they're worried about their time. They're worried about their productivity. They're worried about how long it will take them, right? Who's been in a meeting with a doctor who counts clicks? They have to be worried about their productivity. The challenge is if they had that trouble in ICD-9, that gets worse, not better in ICD-10, right? Some places it's not too much worse in some EHRs, but you've got to be careful. It's not just about the number of clicks, it's how many clicks to get to the right code. You know, what is that going to do when it goes all the way through our process? Is the payer going to pay that? And that's where you get to, you have to understand how the whole process works. When you look at this, the way that most EHR vendors have solved this problem for their clients, it's through a code search process. Now, I know what you're thinking. Wait a minute, that sounds like a pretty good way to do it. And that, in part of, let's think through that. And the reason why that's a challenge for some groups this works very well. For some, it's a challenge, and the reason why is we don't think of search like we used to. Google has changed our brains. I mean, we don't even search for any anymore, do we? We Google it. And here's the way that Google works. You search for an apple pie recipe, and you get thousands of results. But you don't have to look at all of those. 99% of the time, the answer that you're looking for is the very first one, maybe number 2. Right? Google only shows 10 search results on the first page. They think after that it really doesn't matter. I mean, you can go look through it if you want, but nobody ever does. That's why everybody competes for the top spot on Google. But the problem is, when you do code search, it doesn't work that way. If you search for diabetes and you get hundreds of results, you have to read through all of those choices to choose the one that's most accurate for that particular patient encounter. Or your doctor is going to do that. Most are not willing to spend that time. It's like taking an SAT test. Nobody wants to do that. And the first answer is often an unspecified code. And here's why. Most search results are sorted by code order. And the codes that end in 0, right, are going to show up first. And those codes are often unspecified. That's the challenge. You search for CHF, and the first code that you'll get will be an unspecified code, right? Makes it look fast and easy so far, but it won't produce the outcome. It won't produce the results that you want, and you'll get back into that coder biller going back to the doctor asking for them to be more specific later. That's why you've got to be careful to make sure that what you're doing is going to produce the outcomes that you want. Now, certainly biased, but I think the best way to handle ICD-10, both for the doctors and for the revenue cycle, is to use an electronic superbill. Right? We did a survey 2 years ago, found 54% of physicians, regardless of which EHR they use, still used a paper superbill. Now, a paper superbill won't work very well in ICD-10. But the reason why they used it, when we asked, why are you still doing that? It was because it was so fast and effective for them. They could fill it out so quickly with their eyes closed because they know where all the codes are on their page. It was their muscle memory that let them do that. Right? It was their cheat sheet. But at the same time, it got the billing team the data that they need. And you can do the same thing with an electronic superbill in ICD-10. Now, I'm a picture guy. You know, that helps me to kind of visualize something. So let me show you what I'm talking about. The way that you organize ICD-10 codes really matters when you're thinking about this for your doctors. Okay, so let me show you what that looks like. So here's an electronic superbill that we designed specifically for a particular client. Right? It's got the patient demographic information up at the top. And instead of circle, 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 I'm just going to go click, click, click. Right? So maybe I've got a level 3 office visit for a particular patient. Right? We did a lipid panel and a glucose test. I flip over to the back side. I've got my diagnosis codes. All right? Looks pretty simple. But watch this. When I click on something like cough 786.2, it converts that into ICD-10 for me automatically. For most practices, somewhere between 15 to 30% of their most commonly used codes can be converted automatically into ICD-10. Great. What about things that are more complicated? Right? Let's look at carpal tunnel syndrome. When I click on that, it cannot convert that for me automatically, so it gives me a pop-up, shows me my choices, shows me where I need to be more specific. Now, if you'll notice, right, we don't have the unspecified code first. We have it last. Make it least likely to be used. But also, many clients are saying, you know what, don't even show my doctor that choice. Right? There's no such thing as an unspecified arm. Don't show them that choice. It's either left or right. That lets them, with one extra click, make the selection. It closes the pop-up window, puts in the new ICD-10 code, puts in the new ICD-10 description. Okay, well, that's easy when you've only got 2 choices. What about something that's harder? Let's look at this one that has CHF that has many more choices. When I click on that, you'll see I've got 15 choices here. But I don't have to read through all of them. The way the data is organized makes it easy for my brain to recognize the pattern. It puts the type of heart failure, is it systolic, is it diastolic, is it combined, on that horizontal axis. And then puts the onset on the vertical axis. Is it acute? Is it chronic? Is it acute on chronic? right? This is where I need to be more specific. And what that allows me to do, if I've got a patient that has chronic systolic congestive heart failure, boom, right there, I know exactly what it is, where I need to go. And as an added bonus, I've got some doctors that use that encounter form as a reminder for them of who they saw, what they need to do for their documentation, or if they're dictating after the visit. They will a lot of times use this summary tab to remember who they saw, what they did, but it also shows them where they need to be more specific in their documentation. Instead of just saying CHF, I need to say chronic systolic congestive heart failure. That helps me be more specific and get it right the first time in my documentation, so that I don't have to come back and amend the note later. Okay, so think about this. It makes that very easy for your doctors, but also gets the billing team the right data. And we spent a lot of time talking about the doctors because that's the most important thing that you can do, is protect their time to make this easy for them. But what about the billing team? Let me spend just a few minutes talking about that, and then I'll try to answer any questions that you have, because it is a big change to the billing team as well, right? But it's not just a one-day change for them, right? The metaphor that I would use is it's a marathon, not a sprint for the billing team. They're going to be making adjustments for years to come, and they're going to have to be able to respond to that. Let's zoom out and think about this from a high-level perspective. Today, we get paid for CPT codes, right? We're still in that fee-for-service world, and you have to have a diagnosis code that makes it medically necessary. That was true in ICD-9, and that's still true in ICD-10. That hasn't changed, right? If only the billing process were that easy. You still play this cat and mouse game with the insurance carrier, right? These are the hoops and hurdles that you have to jump through in order to get the claim paid. And then to make that even more difficult, not all payers want that done the same way. Now, in ICD-9, which we used for 30 years, it evolved over time, right? The rules would change from month to month, from quarter to quarter. And you probably have people in your office who knew the ins and outs of that game very, very well. They knew what was required. The challenge is that knowledge of how the process works in ICD-9 goes out the door, right? It's not that the cat and mouse game goes away, but it's that the rules of the game change. All the details are now about ICD-10, not ICD-9. And again, the payers are not going to all handle that the same way. That's the big change, right? But it's not just the one-day change, because remember, the payers have never done this before either, right? They've never done ICD-10 before either. They're going to be making adjustments. They're going to be making changes, and they're going to be doing that very, very quickly. That means the volume of change that we are going to see from a revenue cycle perspective over the next 12 months will be bigger than anything we have seen in our careers. Now, you cannot change the payers, right? They're going to do what they're going to do, but you can be prepared to respond, right? And what you have to ask yourself is, if that's what the new world is going to look like, how am I going to manage that? What types of processes and tools do I need to manage that? Who on my staff is going to do that? And maybe the more appropriate question is, what happens if we don't do that? Or what happens if we don't do a good job with that? Right? That's the big question. And so one of the things that we recommend doing for our clients, it's a process that anybody can do, is what we call closed-loop denial prevention. And what closed-loop denial prevention means, it says I can't rid the world of denied claims. There are always going to be new denials. There are always going to be new policies from the payers. But when I see one, here's what I'm going to do. I'm going to go back to the beginning. I'm going to figure out what went wrong what I could have done to correct it. And I'm going to build in a new rule. Now, we would recommend obviously building this into software rather than trying to keep it on a binder or on a notebook or on sticky notes, right? But anybody can do this. Build in a new rule. Figure out what went wrong, how you can make sure that it doesn't happen again. That way, the next time the exact same scenario occurs, whether it's in 2 hours or 2 weeks or 2 months, that rule is going to fire the same way for every single employee every single time. Whether it is the newest billing clerk on my staff or my most senior certified coder, they both have access to the same information so that they can make sure that they get that right this time. Just a quick sneak peek of what that looks like for some of our clients. Using that example of the unspecified code with osteoarthritis that we talked about before, in this example, you can see up at the top, I've got the patient demographic information at the top in the middle. You can see the diagnosis codes. And there's that code right there, M17.9, which is unspecified osteoarthritis of an unspecified knee. Now, the problem with that is for this particular payer, you can see the rule that's firing at the bottom that says, hey, look at this. Blue Cross pays us a reduced reimbursement rate. You see this in the bottom left-hand corner. Blue Cross pays us a reduced reimbursement rate for these types of unspecified codes. Isn't that sneaky? They don't deny the claim outright. They pay us a reduced rate. But this lets you level the playing field with the payers. It lets you make sure that you can correct this before it ever goes out the door. That way you can make sure the claim gets paid completely and correctly the first time. Now, I know we covered a lot of information. I know that I moved through that quickly. I'll put my contact information up here in case anybody has questions after the fact. But I really do appreciate your time. I hope this has been helpful, or at least given you some things to think about as you continue working through ICD-10. Remember, October 1st was really the starting line, not the finish line. And if you can do 2 things for your practice, make sure that you protect your doctor's time and protect your revenue cycle process. So thanks again. Let me see if I can answer some of the questions that have come in. I'll try to be as quick as I can going through these. Yes, for those of you who asked for a copy of the recorded version, I'll make sure that we get that sent out to you. For those of you who wanted a copy of the PowerPoint slides, I'll make sure we get that sent out to you as well.